What's up, everyone? It's Matt Kinney, back to talk about two broad topics on which you should expect to see a lot of questions on your Step 2 CK exam. We will initially walk through the vital steps in the evaluation of patients with traumatic injuries, and then we'll spend significant time discussing perhaps the single most important topic you will see from the surgery section of your exam, shock. We will dissect the different classes of shock and the important considerations in diagnosis and treatment of each. When a patient is found down or has experienced any sort of traumatic or emergent event, there are critical, time-sensitive steps that must be completed to optimize the outcome for the patient. As such, the Step 2 CK test makers like to ask questions which ensure that you know the order of the steps and, more importantly, what to do at each step. The ABC algorithm is an easy way to remember what to do. On the following slides, we will define the steps and make sure you know how to address each one. The first step in the trauma evaluation is to assess extrapulmonary airway compromise. In a question stem, the fastest way to assess the patency of the airway is to note whether the patient is talking. If they are, the test makers are telling you to move on to the next step in the ABCs. If the patient is not talking, you must evaluate potential causes of an airway obstruction, including crush injuries to the head or neck, which might compromise the trachea or other upper airway structures, or evidence of smoke inhalation, which can cause thermal damage to the airway. On your test, they may mention that the patient has burns or charring of the nares or the mouth, which is an indication that thermal airway damage is present. The other issue at play when evaluating the airway is deciding whether a patient needs intubation. There are a few classic indications which require a patient to be intubated, the first of which is facial trauma. If the stem describes a patient with significant maxillofacial or neck trauma, there is the potential for airway collapse, and thus intubation is required to stabilize the airway. If a patient has altered mental status, it means they are unable to protect their own airway and are at risk to aspirate. Finally, and most obviously, if a patient is not breathing on their own, then mechanical ventilation must be considered. We will discuss this indication further when we talk about breathing assessment. Unfortunately, the decision is not only about when to intubate, but also the best method for initiating mechanical ventilation. Thus, we've created the following decision tree to help you work through the decision. Based on details in the question stem, you must decide if you are worried enough about the patient's airway to intubate. If they don't mention altered mental status, significant head or neck trauma, or specifically say that the patient is apneic, you can be certain that intubation is not necessary and move on to assessing the intrapulmonary air exchange, the next step in the ABC algorithm. Conversely, if the patient does require intubation, there are two key situations in which classic orotracheal intubation is not the correct answer. Firstly, if the patient does have significant facial or neck trauma, you may not mechanically be able to place an orotracheal tube due to underlying structural damage, or you may worsen the existing injuries during the manipulation to get the tube down. In this situation, the recommended procedure is a cricothyrotomy, which allows access to the airway distal to the area affected by trauma. The other unique situation to keep an eye out for is a patient in which you are concerned about a cervical spine injury. In these patients, the manipulations required to perform an orotracheal intubation may worsen the spinal cord injury, and in the worst case scenario, cause permanent paralysis. So these patients are intubated using a bronchoscope to minimize the manipulation of the neck. In the absence of these two indications, simple orotracheal intubation is the answer test makers are looking for. Once the airway has been evaluated and any issues have been addressed, the next step in the trauma assessment is to gauge breathing and oxygenation. In practice, the fastest way to ensure that the patient is moving air is via observation of chest rises and auscultation for breath sounds. Thus, if the stem indicates that the patient has normal breath sounds, they are effectively telling you to move on and evaluate circulation. However, The most accurate way to evaluate oxygenation status is with a pulse oximeter, and you should be familiar with the saturation cutoffs you will see on the exam. If the patient has an O2 sat greater than 90, they are oxygenating well and you need not worry. Conversely, if O2 sats are less than 90, you should look to intervene. Initially with supplemental oxygen via nasal cannula, the least intrusive method. If this is unsuccessful in bringing the sats above 90, the next step is an oxygen face mask or a non-rebreather mask. And finally, mechanical intubation may be necessary if none of these less invasive methods raise the sats above the goal of 90. The C of the ABCs requires assessment of the patient's circulation, or, more to the point, their ability to perfuse the vital organs. The initial assessment requires checking distal pulses, often the radial pulse in the upper extremity and the dorsalis pedis or posterior tibial pulse in the lower extremity. If pulses are palpable, the patient is moving blood well. If not, checking more proximal pulses like the femoral in the thigh or the brachial in the arm will provide more information about circulation. Along with evaluating pulses, it is also vital to manage any hemorrhage sites that may be present, and the initial intervention with hemorrhage is always direct pressure to the site of bleeding. Note that even with an obvious brisk bleed in a trauma patient, you must still evaluate airway and breathing first before attending to the hemorrhage site. Blood pressure monitoring allows for a more accurate assessment of blood flow and perfusion. If the patient is hypotensive with hemorrhage, the question stem will be blatant about it. If this is the case, the initial intervention is placing IVs, preferably 2 large bore IVs, and you always want to start by giving normal saline. Blood products may be required later if the hemoglobin or hematocrit drops significantly enough, but the initial goal is just to raise the pressure itself, and the most efficient way to do this is to start with a crystalloid fluid like normal saline. The last 2 elements of the standard trauma assessment likely weren't stressed as hard as the ABCs during your clinical rotations, but they are very important topics on the exam. Once airway patency, oxygen exchange, and perfusion have been addressed, you must evaluate the patient's CNS function, which is most commonly done by assigning a Glasgow Coma Scale score. While it is not necessary to spend time memorizing the criteria for each individual point that makes up the score, you may be asked about the 3 components that go into assigning the score: the eye response, the verbal response, and the motor response. Note that if the GCS score is less than 8, the patient is deemed too altered to protect their airway from aspiration, and thus all patients with GCS scores less than 8 must be intubated. The final step in the standard trauma workup is exposure, also called a secondary survey. In this step, all the clothing is removed to reveal any hidden injuries, and a full physical exam is completed to evaluate for broken bones, neurologic deficits, or abnormal exam signs hinting at internal injury. Let's now move on to discuss shock, an extraordinarily high-yield subject on your Step 2 CK exam. Here's a case to introduce the topic. A woman is ejected from her car after an accident. She is brought to the ED with left-sided chest pain. On exam, she is in significant distress and appears pale and cold. She is tachycardic and severely hypotensive, and jugular venous distension is noted to the level of the angle of her jaw. Chest X-ray shows rib fractures. What is the most likely cause for this presentation? A. Hypovolemic shock, B. Neurogenic shock, C. Anaphylactic shock, D. Cardiogenic shock, or E. Septic shock. This patient is in shock, as evidenced by a severely decreased blood pressure and elevated heart rate. But what kind? In a case of trauma, hypovolemic shock is always a good guess. However, in this case, we get one additional piece of information, JVD to the jaw. This means that blood is backing up in the venous system, indicating that something is wrong with the pumping function of the heart. In this case, the rib fractures caused pericardial tamponade, which leads to mechanical heart failure and cardiogenic shock. As we will discuss shortly, based on the fact that she is pale and cold, we can immediately rule out the three distributive varieties of shock: anaphylactic, neurogenic, and septic. While there are many underlying causes of shock, each with its own nuances, shock itself is the common pathway that results from the impaired perfusion of the body's vital organs. As mentioned previously, the topic of shock is heavily covered on your exam, and while you will be expected to quickly differentiate between the types of shock, it is also vital to understand the pathophysiology of the condition discussed here. With the decreased delivery of oxygen that results from poor perfusion, these organs shut down, causing the classic signs and symptoms of shock. In terms of diagnosing shock, the most obvious change occurs in the vital signs, with a significant decrease in blood pressure. The heart rate will also be elevated as the body tries to compensate for the decreased blood pressure by moving more blood. As perfusion of the brain decreases, these patients present with altered mental status, ranging from confusion to stupor to coma. The kidneys are extremely sensitive to decreased blood flow, and with the onset of shock, blood filtration and waste excretion cannot occur, so urine output will decrease and the BUN creatinine ratio becomes elevated. The liver receives a very large percentage of the cardiac output, and when underperfused, liver cells die and release massive amounts of liver enzymes into the bloodstream. This condition is called shock liver. Finally, underperfusion of the heart muscle itself via the coronary arteries mimics heart attack symptoms of chest pain and shortness of breath. It should be noted that this finding is usually delayed. The first type of shock we will cover is hypovolemic shock, in which the intravascular volume becomes so depleted that it cannot provide the necessary blood flow to the vital organs. While blood loss from hemorrhage is certainly the number one cause of hypovolemic shock, it should be noted that other things can cause it as well, including severe dehydration and burns, both of which can lead to a loss of total body water and a resulting decrease in the intravascular volume. While you should always read the full question stem and interpret all of the data given, if the case describes a traumatic accident and a patient is in shock, most of the time it's a safe bet that you are dealing with hypovolemic shock, and if there isn't an external source of hemorrhage, the patient may be hemorrhaging internally. The physiologic response to decreased intravascular volume is vasoconstriction of the skin and extremities in an effort to keep the vital organs perfused. This is why the patient will appear pale and cold. Blood is being shunted away from the skin and toward more important structures. As mentioned previously, trauma is always a good hint as well. The lab findings are vital in diagnosing the cause for shock, and you must become very comfortable with each of these measurements to quickly and accurately figure out what is causing the shock and how to treat it. These same lab values will be discussed for each class of shock. In hypovolemic shock, the systemic vascular resistance is high for the same reason that the patients appear pale and cold. The body is constricting all of the peripheral vessels to shunt blood to the brain, heart, and lungs. The central venous pressure and pulmonary capillary wedge pressure are both decreased because there is a decreased amount of intravascular blood to keep the pressures up. And since cardiac output is partially dependent on filling volumes, it is decreased as well. The treatment of hypovolemic shock is focused on increasing intravascular volume while simultaneously normalizing blood pressure. Thus, IV fluids must be given, starting with a crystalloid like normal saline, and pressor medications are given to maintain or increase blood pressure. In cardiogenic shock, the patient is effectively experiencing severe systolic heart failure with a low cardiac output, and as such, the heart is unable to pump enough blood to perfuse the vital organs. This situation can occur secondary to an MI, the most common underlying cause for cardiogenic shock, as well as severe congestive heart failure or certain arrhythmias. As seen in the case we discussed a few slides back, cardiogenic shock mimics hypovolemic shock from a symptomatic standpoint, because again, the body is vasoconstricting the peripheral vessels to ensure that what little cardiac output is being generated is shunted towards the vital organs. Thus, patients again appear pale and cold. While the question stem doesn't have to give you symptoms of cardiac pathology, because you can differentiate the two conditions based on the labs, if they do mention cardiac symptoms like chest pain and shortness of breath, or if they mention JVD, a classic finding indicating heart failure, your index of suspicion should be high for cardiogenic shock. By definition, cardiac output will be low and systemic vascular resistance will again be elevated due to vasoconstriction. But in this case, the central venous pressure and pulmonary capillary wedge pressure are elevated because the pumping function of the heart is failing, and thus blood is backing up into the lung vasculature, the right side of the heart, and the venous system. The reason it is vital to differentiate between hypovolemic and cardiogenic shock is that the treatments are completely different. In cardiogenic shock, you must diagnose and treat the underlying cardiac problem, whether it be stenting for an MI or correction of an arrhythmia. While these options may be beyond the scope of your Step 2 CK exam, what is vital to remember about cardiogenic shock is that giving IV fluids will worsen the situation and can potentially be deadly. The patient's heart is struggling to pump the blood volume that is already present, and giving more volume will just make a bad situation worse. We will now move on to discuss several types of distributive shock, in which perfusion pressure to the vital organs is lost because a normal intravascular volume of blood is being incorrectly distributed to the wrong organs. The first type is neurogenic shock, which results from damage to the spinal cord, usually at the level of either the cervical or thoracic cord. Peripheral vasoconstriction is mediated by the sympathetic nervous system. When this sympathetic innervation is disrupted after a spinal cord injury, the result is uncontrollable and widespread vasodilation of all the vessels in the skin and extremities. In effect, the body can no longer control where blood flows, and it loses the ability to shunt blood to the vital structures. Symptomatically, these patients appear warm and flush because there is greater than normal blood flow to the skin. The stem will also likely mention some sort of trauma or other CNS symptom that would indicate a spinal cord injury. In these patients, the blood volume is able to spread out so much into the peripheral vessels that not only is the systemic vascular resistance low, as would be expected without the ability to vasoconstrict, but the pressures are low globally, including CVP and pulmonary capillary wedge pressure, and cardiac output is low as well. Treatment of neurogenic shock is triggered on maintaining blood pressure by increasing intravascular volume with IV fluids, as well as maximizing vasoconstriction with pressor medications. Septic shock results from the presence of bacterial endotoxins in the bloodstream as a result of infection. While many organisms are capable of producing these toxins, the two most common bugs are E. coli and Staphylococcus aureus. In effect, the endotoxins produced by these bugs induce global vasodilation, and thus septic shock is a second example of distributive shock. These patients will also be warm and flush, much like the patient seen in the image to the right, and the question stem will likely hint at a potential source of the infection leading to sepsis, commonly a urinary tract infection or pneumonia, with wound infections being slightly lower on the list. In these patients, the global vasodilation leads to low systemic vascular resistance and low central venous pressure, but the cardiac output is actually increased secondary to the infection, and thus blood does not back up into the pulmonary vasculature, and so wedge pressure is essentially unchanged. Treatment of septic shock requires a two-pronged approach. First, you must attack the source of infection with a broad-spectrum antibiotic. While this will help kill the bug causing the hypotension, you must also work to maintain blood pressure to ensure appropriate perfusion, again using crystalloid IV fluids as well as pressors with alpha-1 activity such as high-dose dopamine or norepinephrine. The final type of shock we will discuss is anaphylactic shock, the third class of distributive shock. In anaphylaxis, an allergic reaction to a certain substance results in the unhindered release of inflammatory mediators, specifically histamine. Histamine has many effects in the body, one of which is vasodilation, again leading to increased blood flow to the skin and the appearance of warm, flush patients. These patients will also present with other effects of histamine, including wheezing due to histamine-induced bronchoconstriction and hives, which are seen in the image to the right and occur as a result of leakage of fluid from capillaries into the dermis. From a laboratory standpoint, these patients have low central venous pressure and low systemic vascular resistance, as expected with all types of distributive shock, and their capillary wedge pressure is also low, which differentiates anaphylaxis from septic shock. The differentiating lab finding from neurogenic shock is that in anaphylactic shock, histamine acts as a chronotropic agent, increasing the heart rate and the cardiac output. Treatment of anaphylaxis shock requires immediate epinephrine injection, which induces vasoconstriction to raise blood pressure and also acts as a bronchodilator to prevent wheezing and respiratory compromise. Due to the importance of being familiar with the similarities and differences between the different types of shock discussed in the last 10 minutes, we have created a high-yield decision tree, which will help you take the information provided in the question stem and use it to quickly diagnose these conditions on the exam and select the correct treatment. When provided with a patient with low blood pressure and elevated heart rate that is clearly in some sort of shock, the first thing you should look for in the stem is a description of their physical appearance. If they are described as pale or cold, it means that the body is shunting blood away from the skin and you are dealing with cardiogenic or hypovolemic shock. To differentiate these two, evaluate the pulmonary capillary wedge pressure. If elevated, it means that the heart is not pumping efficiently and blood is backing up into the pulmonary system, a telltale sign of cardiogenic shock. These patients should be treated by addressing the cardiac issue and not by giving them additional IV fluid, which could kill them. Conversely, if the wedge pressure is decreased, it is due to the global decrease in intravascular volume, and you must provide immediate fluids and pressors to rescue the blood pressure. Now, if the patient is described as warm or flush on initial exam, you are dealing with one of the three types of distributive shock and should next consider the cardiac output. If it is decreased, it means that the patient is experiencing neurogenic shock from a spinal cord injury and requires fluid and pressors to maintain the blood pressure. If the cardiac output is elevated, you again must rely on the wedge pressure for your final determination. If the wedge pressure is decreased, it is because histamine has been released after an anaphylactic reaction, and the patient must be treated with epinephrine to not only raise the blood pressure, but also to combat the bronchoconstriction caused by histamine release. Conversely, if pulmonary capillary wedge pressure is within normal limits, endotoxin release from an infectious agent is the cause of your patient's low blood pressure, and antibiotics must be given along with fluids and pressors. Okay, that's it for this lecture. Remember that it is important to know the different types of shock cold for this exam, so make sure to spend time learning the pathophysiology behind each of these conditions. Next time we'll be discussing two more big topics for your Step 2 CK exam, thoracic and abdominal trauma.